This was a piece of research focusing on health inequalities, and we were looking at two clinical conditions. We were looking at heart disease and depression, and we're wanting to understand how health inequalities arise during consultations in primary care. So we're looking very much at consultation processes, looking at the sort of micro processes of doctors thinking about patients, and also looking at the interventions that they would carry out during a primary care consultation.
Have you had any chest pains at all?
It didn't involve real patients because we needed to have some sort of experimental control and be able to look at differences in terms of characteristics of doctors, characteristics of patients, and healthcare system differences. We used actors to simulate patients, so we constructed detailed videotaped vignettes of patients presenting with all the cardinal signs of coronary heart disease in this case. And we presented these to doctors, both US and UK doctors. They were randomly selected but stratified so that half were male doctors, half were female doctors, and we had a mix of experience. And we showed them these videotape vignettes in the context of their own consulting room and asked them to consider them as their own patients and treat them within the constraints that would normally be in existence within their own practice. And we got them to talk through afterwards their thoughts about the patients. We were interested in their thought processes and trying to see where health inequalities might originate, to see if we could locate them in how they were starting to think about patients. Whereas a lot of previous research has looked at outcomes in terms of interventions, but we were trying to understand the step prior to that. Most of the doctors had heart disease within their differential diagnoses, so they had up to 6 possibilities of what might be wrong with these patients, and most of them had heart disease in there. But when we looked at the sort of nitty-gritty of their thinking, we found some interesting differences. There was less certainty, and that was statistically significant, associated with the diagnosis of heart disease amongst the women patients compared with the men. We found that female doctors recalled very much more information about the patients, so they were remembering many more things that they told them or how they presented their story. And this was particularly true when they were consulting with women patients. They remembered much more about the women patients. However, a key finding was that within that they didn't particularly pick up on women's age, as that's obviously an important factor, a risk factor for heart disease. As women's age increases, well, as men's age increases, they are more likely to suffer from heart disease. And it's hard to explain, really. I think a lot of medical research has involved men in the past. A lot of randomised controlled trials have involved men and not women, and that's very well documented in sociological literature around medicine. So I think in terms of disease models in doctors' minds, they're not so well developed for women as they are for men. There are still beliefs around that heart disease is very much more a male disease than it is a female disease, despite the high burden of disease that we know is out there. There needs to be a bit more awareness raising about, what heart disease looks like in women and what are the risk factors, and more awareness of the statistics perhaps. I'm sure that's coming in primary care now. They're very important. They have their quality outcomes framework and they have their targets to meet. So I'm sure practice is improving all the time in relation to that. But I think it's just a bit more awareness of the importance of age and the increasing risk of heart disease in women for doctors and the general public, and most importantly for women themselves.